So let me introduce our speakers. We do have a panel of three. Dr. Benjamin Hippen is the Senior Vice President and Head of Transplant Medicine for Fresenius Medical Care. He leading the company's worldwide efforts to expand access to and understanding of transplant medicine. He is a clinical professor in the Department of Medicine at the University of North Carolina at Chapel Hill School of Medicine and serves on the board of directors of Interwell Health in North America. He also served as medical director of both a very large in-center dialysis facility as well as a large home therapies unit. We also have Donald Ferguson joining us today. He started dialysis at 24 years old. He was placed in center for 4 years before he had the opportunity to go to a next stage for 2 years. Don finally received a kidney transplant on February 24th, 2016. Now he is a patient consultant. As a patient consultant, he helps educate patients and their loved ones on the benefits and drawbacks of becoming a home dialysis patient by using his own personal experiences with the therapy. And we also have Elizabeth McNamara. She is the Chief Administrative Officer at Northwest Kidney Centers. Northwest Kidney Centers is the world's first dialysis organization and has led the way for kidney disease treatment and research since 1962. Liz joined Northwest Kidney Centers in 2018 as the Chief Nursing Officer and brought over 30 years of healthcare and leadership experience. She has oversight of all clinical areas of NKC as well as strategic growth. She has worked to advance leadership development, quality and safety, interdisciplinary team development, and equity, diversity, and inclusion. And before we get into our start this session, I just want to acknowledge and thank the patient subject matter experts from the NPFE LAN and the Legacy Group for submitting questions for the expert panelists for today's session. Next slide. So I think I'm going to start with Dr. Hippen. Dr. Hippen, we have some questions regarding transplant that came in from our patients. And we're going to start it off with you. So I want to ask, what are the anti-rejection transplant medications and who pays for those medications?
Great. Well, thank you, Stephanie, and thanks for the invitation today. There are several different types of anti-rejection medications, but the medications that are most commonly in use have been in use for the last 2 decades or more. One is a class of medicines called calcineurin inhibitors, and the most common version of that is called tacrolimus. That's the generic version. It's also sometimes marketed as Prograf, which is a brand version, and another version of that is called Invarsys. So that's one type of medication. Another is called mycophenolate mofetil. That's the generic. It's sometimes referred to as Celcept, and there's another version of that called Myfortic. Most people are on both of those medications in some doses. Some people will also be on steroids. The most commonly used type of steroid is prednisone. In terms of who pays for the medications, it does depend in part on what the patient's primary insurance is. Patient's primary insurance is Medicare, then it's Medicare that is paying for the immunosuppression medications. If the patient has Medicare Advantage, interestingly, it's also still Medicare, or excuse me, it's the Medicare Advantage plan that will be paying for the immunosuppression medications. And if the patient has commercial insurance, it's typically the drug plan under the commercial insurance paying for those medications.
Right, right. So Dr. Hippen, another question for you. Will I be taking a lot of medications after a kidney transplant?
Well, it depends in part on how many medications you were taking before the transplant and for what. Certainly, immediately after the transplant, you'll be taking immunosuppression medications, which could amount to anywhere from 6 to 12 pills a day on average in divided doses, not all at once. In addition, especially early on in the transplant, you may be taking some medicines to prevent developing certain types of infections. Some of those medicines you may take for a longer period of time. Some you may only be taking for a few months. And then again, some people who have high blood pressure or diabetes before the transplant may still have to take their high blood pressure and diabetes medicines after the transplant. I would say on average, transplant patients take 6 to 7 different types of medicines a day, but you may be taking more pills than that because each medicine may come in 1 milligram or different milligram pills that require more than one pill at any given medication dose.
Thank you. And how will the kidney transplant get paid for?
Right. Here again, it depends in part on the patient's insurance. If the patient has Medicare as their primary insurance, then Medicare will pay for the transplant itself, as well as the post-transplant care. For Medicare Advantage, it's actually still Medicare that pays for the kidney transplant. And in the case of commercial insurance, it's the commercial insurer. I didn't mention Medicaid, but Medicaid typically covers kidney transplantation as well as the medications. But the level of payment there is dependent on individual state Medicaid plans.
Right. Thank you. And before we go into Don, just want to remind everybody, all the attendees, please submit any other questions as you're hearing these presentations in through the chat. And we should have a few minutes at the end to go through them. So, Don, got a couple questions for you. With home dialysis, can you travel anywhere in the world, like out of the country?
So, being honest, yes and no. It's really going to depend when you say out of the country, where you're planning on trying to travel to. Certain countries are not going to have the resources to be able to help maintain you with that dialysis treatment. So if I were any patient that was trying to, plan any trip outside of the country, I would definitely just speak with my healthcare team about that. Just make sure you're staying in communication with them and letting them know any plans that you have of traveling, either inside of the country or outside the country. So that way they can make sure that that is somewhere that you can travel and be able to do your dialysis treatment safely. Me personally, I've traveled with that machine and done my dialysis treatments in the hotel room. So it's definitely feasible to travel though.
Right, great, thank you. And thank you for clarifying that. That's great information. Another question, Don. You may have personal experience. What if I'm afraid to stick myself for home hemodialysis?
Honestly, most people are afraid. So you're in the same boat with a lot of us. I was actually terrified of it. So I didn't use the creams that, they always say you can use or the spray. So I was such a baby. I actually had them inject lidocaine into my fistula, which they don't even do that anymore. So I actually didn't want to do home dialysis because that was one of the first conversations I had with my training nurse was, hey, you can't do that at home because there's not a nurse at home to administer that for you. So I almost stopped right then and there. But luckily I had the training nurse I had, and she calmed me down. My wife was there too, and I had to be a big, strong husband and put on my big boy shorts, and I got through it. And honestly, it was all about that first stick, especially as a patient who had been in center for 4 years. Once you get past that, initial anxiety about it, it's really not that bad. And actually, it became way more comfortable, me doing it by myself. So I always tell everybody, if you're scared or nervous about placing those needles, that's okay. Be confident in that. But as your fear about it, try your best to just move past that. There's small little steps that you can take. So I tell a lot of patients, it just depends on what level you are. I meet patients that, they won't even look while they're having those needles placed. So, that could be your first step. Stop turning away when they're trying to place those needles. Watch them place the needles. And then, go on from there, making small steps towards reaching your big goals.
Great advice. Thank you. And one more for you, Don. And do you have to do monthly labs, and where does that take place?
So yes, for me, how that happened was I was trained to take my own labs. So once a month, I would take my labs. What I would do is I would pull them. I had a centrifuge. I would put them in a centrifuge. They would spin. Once I was done with that, I would package them up and I would put them in a refrigerator. And then I would plan to do my labs when I was going to plan to see my training nurse and my doctor. So I had to still see them once a month as well. So everything was like coordinated in that way. I'm not going to say everyone's going to have that exact same experience. You know, everywhere is different. They have different procedures and different ways they want to, you know, conduct things. So what I would do if I was any patient is I would speak with the trainer nurse in your area, you know, just get a confirmation on like how these things are going to happen for me. And don't be afraid to ask questions. You know, if you're not sure about something, you want to know an answer to something, you know, ask that question. There's no such thing as a dumb question.
Thank you. Thank you. Okay, Liz, I got a couple questions for you too from our patients. What can we do to help someone who is against vaccinations?
This is a great question, and we could probably spend the whole day talking about that. So as I saw this reflection question, I really had to think about my own practice, my own conversations, and it really comes down to the individual person's why. You really need to spend time with that person, understand why are they against vaccinations? Is it vaccinations completely? Is it a certain type of vaccination? And I think in the medical community we tend to dumb things down a little bit too much, quite honestly. And so I think we need to lead with the data, right? So when I talked with patients who didn't necessarily want the COVID-19 vaccine, we have data. We have data about mortality rates for patients that are on hemodialysis and what that looked like. They were 3 times more likely to die after a COVID-19 diagnosis. That's very clear data. They saw their peers within the clinic, right? They saw people get sick. And so I think that really helped me sort of lean into the data, but it really comes down. And at one point, I think about a person that I had the opportunity to talk to, and I said, you know, is there anything that we can say or do or talk about that's going to change your mind? And that was a great question because they really reflected and said, well, I'm not sure. And that was the door opening, right? That was the door opening. I also think making sure that people are going to the valued sources for information, right? The transplant patients, I mean, American Society of Transplantation is the best source of information. There's so much information on that website. It's patient facing, it's healthcare worker facing. The CDC, the ACIP is the Advisory Committee on Immunization Practices, and they've got patient facing, family caregiving facing information. So I think those are the conversations that really help really drive that, make sure people are as well informed as they can, and really provide that data because we have the data. If it's flu vaccine, COVID vaccine, we actually have the data. What we don't have as much, we have some individual studies just on our patient population, just on the ESKD patient population. The DCI did a great study. So again, happy to share any of the resources that I've actually referenced with this group.
Right, thank you. And I'm not sure this is an easy question either for you, but can you explain the different types of the pneumonia vaccines?
Well, I love the pneumonia vaccines. I'm just going to say that out loud. And again, I'm going to put people to the CDC site. So there's a bunch of different pneumonia vaccines, right? And so you've got pneumococcal conjugate vaccines, which are the PCVs. And so I'm going to talk about that in just a second. And I know Dr. Hippen's probably going to jump into, and that's totally fine, Dr. Hippen. So you've got PCV and then a number after that, right? 13, 15, 20. So the number reflects the numbers of serotypes of the streptococcal pneumonia variant that it protects against. That's what the number means. And so the PCV means it's a conjugate type vaccine, which is a vaccine that joins a protein to an antigen in order to improve the protection the vaccine provides. So that's PCV. So then they throw in PPSV, right? What is PPSV 23? Well, the number means the same thing. So at least that's consistent. And the PPSV stands for pneumococcal polysaccharide vaccine. So, polysaccharide, that's got to have something to do with sugar, right? So that's exactly what it is. It's a type of vaccine that's composed of long chains of sugar molecules that resemble the surface of certain types of bacteria to help the immune system mount a response. So again, that's kind of what it is. Now, what does it mean? Like, how often should you get it? Well, with the PCV 20 that just came out, it's kind of a game changer in this space. And Northwest Kidney Center has actually just launched a big campaign. And so we now have access to the state database, so we can actually help our patients with what have they gotten, what haven't they gotten. And so we have a tip sheet now. So we're really pushing the PCV 20. Now, I think a lot of people know that, well, if I got the 13 and I was greater than 65, what does that mean? I mean, again, talk to your provider, right, for sure, because your provider said, no, we're going to go ahead and do it. The time space between the 13, the 15, and the 20 really is, so the 13 does 13, right? The 15 does the same 13 and adds 2. So you want that time lapse before you get the next dose so that you get a better immune response. Hopefully that made sense.
I know that's not an easy.
It was good, right? We did pretty good, right? You got to love the CDC, guys. Seriously.
And one more for you, Liz.
Yeah.
Do you recommend that the dialysis patients get a shingles vaccine?
This is a great question. And I think the other question is about the live vaccines and the dialysis patients. So just to back a step up, so we all know that patients that are on dialysis are more at risk for infection. They're not classified as severely immune compromised like the transplant patients are. So there's a difference, right? You see that difference in the vaccine response. You see that difference. So again, talk to your provider. That's always going to be my disclaimer, but there really is no true contraindication to a dialysis patient receiving the shingles vaccine, if that's the question.
Perfect.
Ben, do you agree? Thumbs up.
I do agree.
And I just called him Ben. This is the first time I met him, and we're old friends.
Okay. Well, and Dr. Hippen, back to you. Is there any reason patient is discouraged from accepting a high-risk kidney?
Patients are often discouraged from accepting high-risk kidneys, though it's not clear that they often should be discouraged from doing so. I think we should start by clarifying what we mean by a high-risk kidney, because that's a term that's used in a lot of different contexts. So for some types of deceased donor kidneys, and we're now talking only about deceased donor kidneys, high risk is attached to patients or deceased donors who have additional medical problems at the time of their death, like high blood pressure or diabetes or advanced age. These are so-called high-risk kidneys that are referred to as high KDPI kidneys. KDPI is an acronym that stands for Kidney Donor Profile Index. It's a score from 1 to 100. 100 is the highest kidney donor profile index and typically connotes the highest risk. 1 is the lowest. And that score is based on certain facts that we know about the donor. That being said, those kinds of high-risk kidneys can often be quite beneficial. In fact, I'll put in the chat a study that was just published a few days ago by some of my colleagues that describes, and I'll just put that in the chat there, that describes actually the benefits of preemptive transplantation with high KDPI, i.e. high-risk kidneys, suggesting that in fact, if you get transplanted with a high KDPI kidney, so-called high-risk kidney, before you start dialysis, those patients actually have survival comparable to getting transplanted with a normal risk kidney after starting dialysis. So for a number of patients, accepting a high KDPI kidney or that kind of high-risk kidney might well be advisable. Another way in which high risk is used is referring to donors that in the course of taking the donor's social history, the organ procurement organization personnel may have identified some high-risk behaviors that may increase the risk of donor disease transmission, certain types of viral infections such as hepatitis or HIV. I think the thinking in the transplant community about these kinds of so-called high-risk donors has changed, particularly with regard to hepatitis C infected kidneys, because of the availability and really the superb performance of anti-hepatitis Z virus drugs, to the point where there's now discussions in the transplant community about eliminating the reporting of hepatitis C as part of the data that we report to the transplant registries, because the outcomes for these hepatitis C positive kidneys are so good. I think in each case, it's important to discuss the risk factors of the individual donor with the transplant nephrologist or transplant surgeon who's offering this particular kidney. But generally speaking, I think that the previous concerns that my colleagues and I in the transplant community have had about these so-called high-risk kidneys have really changed to the point where I think that everyone should be asking their doctor about whether they should at least sign up to be offered these kidneys. Because even if you're signed up, if you consent to be offered these kidneys, you're not required to accept any particular organ offer that's provided to you. But if you don't sign up for it, those kidneys won't even be offered to you. So I typically recommend for most of the patients that I took care of in practice that they at least consent to being offered these kidneys so that it can at least be a tailored, individualized conversation between you and your doctor.
And I'll follow up with that question, that response with that next question. When is a high-risk kidney better than not transplanting?
Right. Well, so I just put the link in the chat there. There's at least one circumstance where all of the things being equal, it might be a good idea to accept a high-risk kidney versus waiting for a so-called lower-risk kidney if it means that you end up on dialysis for a period of time. But there are a number of other circumstances, particularly if you're someone who's on the waiting list for a period of years, if your underlying disease that caused your kidney failure is diabetes, and you don't have an available living donor, if you're looking at a certain number of years on the waiting list before you're likely to get an organ offer, then it probably does make sense to accept a higher risk in the form of high KDPI kidney. I think generally speaking, for the other type of high risk, the donor disease transmission risk, I think generally speaking, because of how sensitive the testing is for the donors these days, the likelihood of disease transmission is extremely low. And so while we specifically consent patients for kidneys from these types of donor, I typically recommend that all of the things being equal, again, there can be certain clinical circumstances that make certain individual donor kidneys different, but all of the things being equal, I typically think of those kidneys as the same as standard risk kidneys. And I recommend to my patients that they typically think about them in the same way, unless there's something specific about the donor case that requires specific consideration or discussion.
Right. And one last one for you, Dr. Hippen, before we move on. If you had a transplant previously and lost it, do you have to go to the bottom of the list?
Great question. It does depend. So if someone receives a kidney transplant and it is deemed a failure within the first 90 days after the transplant, that is typically declared what's called primary non-function, which means that the kidney just doesn't work. Now, primary non-function doesn't mean that the kidney doesn't work at all. Primary non-function can be declared if the kidney has a GFR of less than 20 cc's a minute, or another way to think about that is less than 20% of normal kidney function. So even if the kidney is working a little bit, if at 90 days it's not working more than that and the transplant center agrees, then that kidney can be declared a non-functioning kidney and that patient can reclaim their waiting time. But if a patient has a kidney transplant that subsequently fails after a number of months or years and they are referred for retransplantation, then they do need to go back to the quote unquote bottom of the list. But that's one of the reasons we encourage physicians and patients to watch their overall level of kidney function carefully, because they can be preemptively referred and waitlisted. By preemptive, I mean being referred, evaluated, and waitlisted before they return to dialysis.
Great, thank you. Don, I'm going to swing it back over to you. Is home hemodialysis able to be done alone? And if not, are there any organizations that provide assistance?
So yes, you can do home dialysis solo. It is on a case-by-case basis. As a patient who has done the therapy, so for me, my wife was my partner. So she went to basically every training. She only missed one because she had a doctor's appointment. And so how we did it was basically she learned how to place the needles first, while I learned how to just focus on the machine. And then we switched places. And so once we got home, actually 99.9% of the treatments I did do by myself. She was just there as backup, whenever I need her, if I drop something, what have you. So is it possible for me to have just done everything by myself? Yeah, fully possible. I always say it's better to have someone there though. As a home dialysis patient, I know it's very easy because you're doing home dialysis so often throughout the week. You're just going to get better and better and better at it. But also what happens is complacency happens. So a lot of times patients end up doing things like missing little small steps trying to get through the treatment, right? Simply just forgetting to wash your hands before you start the treatment. So having that partner there is really, really nice, especially with my wife, because she'll say, hey, you're not supposed to be doing that, and get me back in line. But if you need to do it solo because you don't have a partner there, of course, that is definitely a possible route for you. When it comes to organizations that provide treatment, I have heard whispers of some. It is a stretch to probably find one. It just really depends on what areas that you live in. What I would always do is just commonly just do a Google search and you can find out. Always definitely go back and speak with like healthcare professionals again and, ask your doctor, hey, have you heard of any assistant organizations that could help me with home dialysis? Because there may be in your area.
Exactly. My next question, which is a question that comes up a lot and again and again, how much space will be needed for the home hemodialysis supplies?
So honestly, the first shipment is going to be overwhelming. I'm not going to say it's not. And it's because you're not used to getting shipments of boxes to your house like that. And, finding a place to store them can be a task for you to do. But in regards to another personal story, when I did this, I stayed with my parents. So it was me, my wife, my daughter. We shared one room. In that one room was that dialysis machine. I had supplies in my closet. I had some supplies downstairs in the pantry. And then whatever can sit out and not need to be cooled by the AC was in the garage in a spot somewhere. So can you find space? Yes, you can find space. It's just about how much do you want to do this?
Right. And another question for you, Don. How do you handle the disposal of waste products, whether it's for PD or HHD?
Honestly, it just goes right in the trash. After every treatment, I would just, break down, take everything out, put it right back in the same bags that it came in, and then I would just take it and throw it out in the trash. It's legal for you to throw anything from your hemo treatment into the trash because what's left in that machine is about equal to what's in a Band-Aid of blood. So it's really not a lot of body fluid still left in the machine. I mean, in the cartridge after you do your treatment. So it's perfectly okay to just throw it and discard it in the trash. I personally have never done PD myself, but I would definitely assume you would just go ahead and discard that right in the trash as well.
Okay, great. Thank you so much. Great, perfect. Liz, I have a couple for you. Do you still need to keep taking the COVID vaccine shots?
Yes. So as we have all learned, viruses are smart, viruses are tricky. And so they're going to mutate, right? And they're going to change because they're going to survive. So we need to change our vaccines to meet the need. It's kind of like the flu vaccine, right? And so we anticipate that it will be at least a yearly vaccine. We did see a fair amount of waning, especially with the mRNA vaccines. And so it's an exciting time in science. It's an exciting time, but we do anticipate that this is going to be a routine vaccine.
Yeah. I think you had questions earlier. Can you point out the vaccine or vaccines that dialysis patients need to avoid, like the live viruses?
Yeah, so the live vaccines, the live attenuated vaccines that are routinely administered are the MMR vaccines, the varicella, rotavirus, and intranasal flu, although that really fell out of favor. I think we haven't done a lot of intranasal flu this past year. The ones that for international that are not routinely are the adeno 30, the typhoid, and the VCBG. So those are the definitions of the live vaccines. Again, as we said before, dialysis patients aren't in the severely immunocompromised category. So they wouldn't necessarily be excluded from the live vaccines, quote unquote, live vaccines, if you will. Transplant patients, again, a little bit different story, and I would definitely defer to Ben. But again, work with your doc and your care team. But there's no true contraindication for those vaccines for the dialysis patient population.
Okay. And then kind of a two-part or
Yeah.
actually three-part question, but when are vaccinations a bad idea? And then are the vaccines really a guarantee? Pro versus cons based on data, not opinion.
This is a great question. I think you saved all the great questions for me. Certainly kind of the controversial ones. So I'm going to leave my opinion out of it. And again, I'm going to drive the data. We have data. So are vaccines really a guarantee? No. There's not one vaccine out there that's going to say 100% you're not going to get fill in the blank disease, right? There's not one very clearly about that. Well, except for the few that we've gotten rid of and now they're back. But anyway, so the ones that we're talking about right now, so they're not a guarantee, but what we have shown is that it mitigates how sick you get. So let's just talk about the flu vaccine. That's not as controversial as the COVID vaccine, right? There is data, very clear data from probably 15 years ago that we had unvaccinated healthcare workers in a skilled nursing facility, right? They were asymptomatic the first couple days before they actually got sick, and flu went rampant through the skilled nursing facility because those patients were more at risk. So that was very clear data, and that's what drove sort of the vaccine mandates, you will, in the healthcare worker population for the flu vaccine. So very clear data. We have to drive the data. So when are vaccines a quote unquote bad idea? The data doesn't show that they're a bad idea. And again, driving to the right source of information is really key. And we saw this with COVID, right? We saw this with COVID. So driving to those scientifically based, not Dr. Google, but if Dr. Google sends you to the CDC or the NIH or the ACIP, right? ACIP or the ASN patient site or the transplantation patient site, those are really the key sources of information. I think one thing, and now this is my opinion, I just want to state that very clearly. With COVID, I was shocked at how quickly everybody became an infectious disease expert. I work with a lot of amazing infectious disease experts, and it just didn't make sense to me. So that was really hard, and I think that made COVID that much harder. So really, we've got to trust the key sources of information. And if you think about the CDC, they were a little bit late to the party, right? Because they were super careful. So it felt like retrospectively. So I think that's really how I would answer that question. And again, open to any other questions, comments, or thoughts from the panel as well. I think from the patients and their families, it goes back to the first question. What's your why? What's your why about your hesitancy? What's your why? Is there a gap of information, or are you making an informed risk-benefit choice for you and your family?
Right, exactly. All right, great, thank you. And so, Dr. Hippen, is the aftercare for a high-risk kidney transplant the same as a non-high-risk kidney?
Thanks for the question. So again, going back to, depends on what we mean by high-risk kidney. If we're talking about, say, a high-risk kidney from a donor that has hepatitis C, it will be a little bit different because those patients will receive an anti-hepatitis C medication that they'll be taking for 12 weeks. Kidneys from high-risk donors that might be high risk because they have long-standing high blood pressure or diabetes, or from older donors, may be at higher risk for something called delayed graft function. Delayed graft function basically means requiring dialysis right after the transplant is completed, waiting for the kidney to wake up, as it will. In that circumstance, patients may receive intermittent dialysis while the physicians are waiting for the kidney to start clearing toxins and potassium and start making urine and the like. So to that extent, there may be some slight differences in the management. Otherwise, the management is largely the same.
Right. Are the rules for waitlist transplant the same as preemptive transplant?
Right. So patients can qualify for waitlisting. You have an estimated GFR of less than 20 cc's a minute. So what's estimated GFR or eGFR? Many folks who are dealing with kidney disease or have family members that are dealing with kidney disease will be familiar with creatinine, a blood test that's routinely checked in the course of managing one's kidney disease. eGFR, estimated glomerular filtration rate, is an estimate of the amount of kidney function that's based on serum creatinine and a few other variables. Based on those calculations, a patient can qualify for referral, actual evaluation, and waitlisting, that is accruing waiting time, if after they complete their evaluation process, the eGFR is less than 20. So a patient could have had residual kidney function for months or even years before starting dialysis. And if they're preemptively referred and approved for waitlisting, they can accrue several months to years of waiting time before they initiate dialysis, which ostensibly will allow them to get transplanted with less exposure to dialysis. But once someone's waitlisted, they compete more or less on equal footing, based largely on waiting time on the waiting list. There are a few other variables that can move people up or down the waiting list slightly, but again, those are probably beyond this conversation here today. For the most part, it's driven by waiting time.
Okay, right. And this isn't probably not a real easy question to answer in just a short amount of time, but what is the process to get on the kidney transplant list?
Well, it should be, in principle, it's easy to explain. In practice, it can be quite convoluted and complicated. Yeah, I see Donald smiling and nodding his head there. It can be quite a roller coaster ride. I mean, the simplest version is your doctor refers you to a kidney transplant or a kidney transplant facility, a transplant center. The transplant center then receives that referral, has a look at it, and if it is complete and it looks like based on the initial review that person might be a candidate for a transplant, the patient gets invited to the transplant center for an initial evaluation and maybe an education session. If all that goes fine, then the patient is set up for set up for appointments to meet about a half a dozen or more people in the transplant center, including the transplant nephrologist, the transplant surgeon, the transplant dietitian, the transplant social worker, the transplant coordinator, and the transplant financial counselor. So after all those visits and additional testing, which involved, typically a chest X-ray, some cardiac testing sometime if there's concern that the patient may have some underlying heart disease, laboratory testing, and all of those visits, then if all that goes well, the patient is then put on an agenda for a transplant selection committee where all the people that patient saw get together in a room and each of them review their individual piece of that patient's evaluation. And then if they all agree, that patient can be placed on the transplant waiting list. Because you get a sense of how convoluted and complicated this can be, it actually can be quite easy for patients to fall off track or get lost in this process. So advocating for yourself or having someone who can advocate for you, or ideally both of those things, is very important for getting through this process efficiently. And I'll just say at Fresenius, we are working to try and improve the efficiency of that process. We're rolling out today an IT referral platform in all of our dialysis clinics across the enterprise, which will help to streamline and consolidate the key clinical information that transplant centers need to make initial triage decisions and deliver that electronically to transplant centers so they can respond to referrals quickly.
That's wonderful. Good to hear. So So Don, I'm going to move on to you. Do you have any, do you have any comments about the transplant, being a transplanted patient? I see
He
you up
just
there.
made it
Is there
sound
anything
way
you
too
might want to
easy.
comment on that?
He made it sound way too easy. And then he forgot the stress test.
So a couple questions for you. And what was the hardest part of the home hemodialysis training process?
For me, I would definitely say the needle part is always going to be the most difficult. And for most patients, I think it's the same. Um, it's because honestly, the machine, it's not very difficult to me to use. And maybe certain people would have a little bit more difficulties than others, of course, and that's fine. Everyone learns differently. Everyone has their own learning pace to things. But for me, yeah, I would just always say it's going to be learning how to place those needles, getting over that first initial shock of it and the anxiety part, and then pushing past it.
Yeah, yeah. And another question, what is the cost of PD or HHD? And they're referring to like additional, like either plumbing, electrical, shelving, etc., things like that.
Me, honestly, I never really saw a difference in utility bills or anything like that. So, water bills stay pretty much the same, electricity bills stay pretty much the same. Like I said, I stored most of my things in like closets or pantry areas or garages, so I didn't pay for like shelving or anything like that. The only thing I had to go out and purchase for myself was paper towels. Everything else was provided for me, all the way down to having a dialysis chair at my house was provided for me. So, I had hand soap delivered, bleach to wipe things down, just hand sanitizer, whatever you can think of that they have in that dialysis center, they provide for you to use at home too, as well.
And I guess this would be in your opinion here, Don, what would prevent a patient from qualifying to be a candidate for home dialysis?
Yeah, that's a real funny one to touch. I think it would just be on a patient to patient basis with that. I would never put, because a lot of patients think it's like some kind of age range of being able to do home dialysis, and that's definitely not true. It just really depends on you, honestly. Like I know of 80-year-olds, 90-year-olds that are doing home dialysis. So it's just really all about the mindset of the patient, and are they willing to, go through the training, learn the machine, and then once they get home, stay on task with what they've been trained to do. If you're willing to be able to do those things and you physically can move your supplies wherever you need them to move without any assistance or anything like that, or if you need assistance, you have that assistance to be able to do that, I don't see really anything that's stopping you from doing that. It's just really about you and what you want.
I think that's so true, Don, if I could just add on to that. And it really does come from the organization too. I mean, there's certain organizations, right? I mean, you have to take a leap of faith sometimes, right? We've actually had a person that was blind be able to do home PDE. So giving people a chance, having things in various other languages, really can break down those sort of equity barriers that we face, especially for home hemo, right? Like in the state of Washington, you have to do some plumbing adjustments. Well, if you're renting an apartment, right? Is the landlord going to allow you to do that? Who's going to pay for it? So I do think that the lens is changing on home as we really want to have people do home because that's the best bridge to a transplant, right? So it's great, Don. Thanks so much.
Yeah, and I'll even comment on that. Just because you have to do, some type of fixture of water, that still doesn't stop you because you can use bags.
That's right.
It's just about having a conversation
Yep.
and bringing up whatever issues you feel like would be problems with the training nurse, or you can even call and speak with a patient consultant. I'm plugging now, but still, it's all these different options that you can do, and the first thing you need to not do is just say, I can't do that.
It's true. We had a patient that after actually rafted down the Grand Canyon with his home hemo machine.
Oh, wow, that's amazing.
And I know somebody drove cross country in an
Right.
RV. So
Right.
yeah.
I guess, yeah, I'm just keeping mindful of our time, and I want to give maybe Liz one more opportunity here. And a couple of these, Liz, kind of cross over to maybe Dr. Hippen's area too.
Absolutely. Yeah, no, I looked at those questions, and then when I
Yeah.
heard that Dr. Hippen was on, I'm like, I think we should probably punt some of those to him.
So I'll put this out to either one. And again,
Yeah.
because they were kind of leaning toward transplant, but I put them over to you. But so either one, are vaccinations as effective for transplanted patients as the general population? It doesn't really say which vaccinations. So
Yeah, so I mean, I would just give a broad brush, and then I'm going to turn over to Ben, my new best friend Ben. So it really is the immunosuppressants that the patients are on that impact the efficacy of the vaccination. It's not necessarily the vaccinations themselves, it's the uptick and the response. And so we have seen in general a more inhibited response to certain vaccinations. Ben, do you want to add some color to that?
That is correct. That being said, and I know, Liz, you would agree with this, the fact that being on immunosuppression medications reduces the efficacy of vaccination does not in any way change the recommendations for getting vaccinated.
Correct.
And
Correct.
I wanted to actually underscore something you said earlier about the efficacy of vaccines. The efficacy of vaccines is not just in prevention of disease, but it's also in reducing the severity of infection. And we've seen this both in the patients of the population of patients who are on dialysis, as well as patients who are transplanted, that the efficacy here really can be making a severe illness a minor illness. And that is not a small thing, particularly when it comes to something like COVID-19.
Correct.
right. And I think the last, maybe the last question was, we were about 2 minutes. So if and if a transplant patient gets COVID, what is the current treatment? Again, that could be.
It depends on the
anybody.
severity of the disease, right? It depends on the severity of the disease and some of the medications that folks are on. Again, the link to
severity and the timing.
Yep.
That's right. So, and by timing, I mean many of the current interventions are much more efficacious if they are started much sooner in the disease course than later. Some have no efficacy if they're started later, and are sometimes used as salvage therapy for patients who are very sick, critically ill in the hospital.
Mm-hmm.
But the treatment is very much individualized, in part because there are certain occasions in severe disease where it's a question of whether the medicine to suppress the immune system should be changed or reduced in order to help the immune system reconstitute a bit to fight off the infection. These are, I wouldn't dare generalize about whether that should happen individual patient to patient. That is a very specific, individualized clinical decision. But by and large, the treatments for transplanted patients versus non-transplanted patients overlap a lot. There are some medications that it's actually a little more challenging in dosing these patients with advanced chronic kidney disease or end-stage kidney disease because of how they're metabolized. So it's we've learned a lot in the last 3 years about this, certainly more than we knew at the beginning of the pandemic. But it's still a complex area.
Right.
And it really does highlight the need for testing and early testing and really staying on top of that. I mean, that really is, and I think that's one of our biggest challenges with the rollback of the PHE, public health emergency, is that we want to make sure that our patients, specifically our transplant patients and our dialysis patients, have access to vaccine and testing continually. So I just want to put that plug in there for folks.
Yeah, and Dr. Hippen, I know we're right at the top of the hour, but real quick, as far as you know, do most transplant centers require the COVID vaccines for part of their transplant workup?
Well, that is a great question and a moving target. And so, since we do have a very limited time, what I will put in is a link to a survey that I actually published in the American Journal of Transplantation last year that outlines, at least then, what the policies of transplant centers were. I'll tell you that just even since we conducted and published that survey, the policies have changed a bit, probably in the direction of more transplant centers requiring vaccination. But as you'll see from the survey, where we asked not just about whether candidates for transplantation required vaccination, but whether living donor candidates did, whether caregivers did, and the like, you'll see there's again, this was conducted in the fall of 21 and published in 22 when we were sort of in the thick of it. So this is the most comprehensive assessment of that I'm aware of. In fact, if you're really interested, there's another version of this looking at it internationally, which I'll also put in the link. It's the same survey, just internationally, and you can see it's kind of all over the place. But your transplant center should have written policies if you have specific questions about your own individual transplant program.
Right. Well, thank you all very much, Dr. Hippen, Donald, and Elizabeth, for being here. I think it was a great conversation. I saw a lot of stuff going on in the chat, and I appreciate all of you responding and dropping resources in there and links for the viewers today. I really think this has been a great panel discussion today, covered a lot of things. You all brought different perspectives, and I think it's been just really wonderful. So thank you all for being here so much. Really appreciate it.